Usually when we talk about aging, we expect this sort of um, gentle, predictable transition.
Right, yeah, like a gradual shift.
Yeah, exactly. Like autumn turning into winter, the leaves slowly change color, the air gets a little crisper each day, and, you have plenty of time to dig your heavy winter coat out of the closet.
You do. The environment shifts, but your body is given this crucial grace period to adapt.
Right, the grace period.
The body absolutely relies on that. In biological terms, we call it acclimatization. Your internal systems are they're slowly adjusting to a completely new seasonal baseline.
Okay, but imagine if instead of that slow, gentle autumn transition, you were sitting on a sunny beach in the middle of July, and instantly, like in the blink of an eye, you were dropped into the freezing, pitch black dark of the Arctic Circle.
Oh, wow. That's a jarring image.
Right. No winter coat, no warning whatsoever, just an immediate, violent change in your environment, and your body is left completely defenseless against the cold.
That visceral image is probably, well, it's the most accurate way to describe what we're unpacking today. We're talking about a systemic shock.
Yeah.
An event that leaves the entire physiological system basically scrambling in the dark to catch up because the internal environment changes in a matter of hours.
So welcome to today's deep dive. We are exploring a topic that fundamentally alters the landscape of a woman's body overnight, and that is surgical menopause.
It's such an important topic.
It really is. We're going to get into what exactly the mechanics of it are, how it occurs, and, why the fallout is so drastically different and honestly so much more severe than what we usually think of when we hear the word menopause.
It's a vital conversation, largely because it is a hidden experience. I mean, so many women undergo this, yet it remains heavily misunderstood or just entirely glossed over in broader conversations about women's health.
Yeah, glossed over is the perfect way to put it. So to figure out how to survive this metaphorical Arctic drop, we dug into the gold standard playbooks to see how modern medicine handles this.
The real heavy hitters.
Exactly. Our insights today are pulled from a really comprehensive stack of clinical guidelines and patient information leaflets. We're looking at material from the British Menopause Society, the Royal College of Obstetricians and Gynecologists, the Vassar Center, and various expert medical toolkits.
Yeah, these sources are essentially the architectural blueprints for how the medical community approaches, manages, and ultimately attempts to mitigate the shock of this condition.
Right. We aren't just looking at the surface here. We're looking at the foundational rules of care. So our mission today is to demystify this entire process for you.
To really break it down.
Yeah. We're going to explore how surgical menopause fundamentally differs from the natural aging process, the deeply complex clinical reasons it occurs, the immediate shock it sends through the body's chemistry, and how modern medicine steps in to protect a woman's long-term health.
It's a lot to cover.
It is, so get comfortable, because we are going on a fascinating journey into the hidden chemical mechanics of the human body. Okay, let's unpack this. Considering how drastic pulling the plug is, we first need to establish a baseline, I think. Let's look at the autumn transition first. What is natural menopause mechanically doing?
Right, so natural menopause is a gradual, multi-year biological process. In the UK, the average age this occurs is 51.
Okay, 51.
Yeah, with the normal expected range sitting between, say, 45 and 55. Over the course of several years, a period we call perimenopause, the ovaries slowly run out of mature eggs.
Got it.
And as that follicular activity slows down, the levels of hormones the ovaries produce, primarily estrogen and progesterone, well, they start to wildly fluctuate and eventually deplete.
Oh, it's a biological fade out.
Exactly. A biological fade out.
I always think of it like a dimmer switch. You are slowly, over the course of years, turning down the lights in the living room. Your eyes have time to adjust to the dimming light. But surgical menopause, that is pulling the plug right out of the wall.
That is the defining difference, yes.
Yeah.
Surgical menopause is the sudden, immediate onset of menopause caused exclusively by a bilateral oophorectomy.
A bilateral oophorectomy, that's the clinical term for removing both ovaries.
Yes. The surgical removal of both ovaries performed prior to the age of natural menopause.
Right.
And the literal moment those ovaries are severed from their blood supply and removed from the body, the production of those vital hormones drops off an absolute cliff.
And so the body doesn't even get a warning shot. The factory is just boarded up overnight.
Completely shut down.
So why force the body into the Arctic like that? What are the medical scenarios where doctors and patients decide that, pulling the plug is the best option?
Well, we can break the clinical rationale down into three main categories. The first, and incredibly common, is risk reduction. We are primarily talking about women who carry BRCA1 or BRCA2 gene mutations.
Ah, okay. These are the genetic mutations that are heavily in the public eye for being strongly associated with aggressive breast and ovarian cancers, right?
They are, and the statistics tied to these mutations are incredibly heavy. For a woman carrying a BRCA1 mutation, she faces a 39 to 44% lifetime risk of developing ovarian cancer by age 70.
Wait, up to 44%? That's almost a coin toss.
It is. And she also faces a 55 to 72% risk of developing breast cancer.
Oh, wow.
Yeah. BRCA2 mutations carry similarly daunting risks, although the ovarian cancer tends to develop at a slightly later average age.
Those numbers represent a terrifying ticking clock. So for these women, the surgery is purely preventative.
Yes, entirely preventative.
Yeah.
For BRCA1 carriers, clinical guidelines strongly recommend this risk reduction surgery, specifically removing the ovaries and the fallopian tubes between the ages of 35 and 40.
That young.
Yeah, and for BRCA2 carriers, the window is generally recommended between 40 and 45. But the protective payoff is massive. This single procedure can slash the risk of ovarian cancer by 80 to 95%,
That's incredible.
and simultaneously cuts breast cancer risk by 50%.
I mean, I try to imagine the sheer psychological weight of that decision. These women are basically trading the very high, looming terror of cancer for the absolute certainty of early sudden menopause.
It is a profound, life-altering choice.
But cancer prevention isn't the only reason the factory gets shut down, right? I can wrap my head around life or death prevention, but the sources also detail women doing this for benign conditions, which initially really surprised me.
Right. Well, the term benign in medicine simply means non-cancerous.
Okay.
It absolutely does not mean harmless or pain-free. We are talking about benign but incredibly severe life-limiting conditions.
Hmm.
The prime example here is severe endometriosis.
Right.
This is a disease where tissue similar to the lining of the womb grows wildly outside of it, attaching to the bowel, the bladder, the pelvic walls.
And because that rogue tissue responds to the body's natural hormone cycles, it acts like a rogue menstrual cycle inside the pelvic cavity, right? Causing internal bleeding, inflammation, and just debilitating chronic pelvic pain.
Precisely. It creates a horrific cycle of pain. Similar extreme pain can be caused by severe fibroids or recurrent massive ovarian cysts.
So when do they actually decide to operate?
Well, when multiple surgeries and medical therapies fail to give a patient any quality of life back, removing the ovaries becomes the final option. By removing the ovaries, you halt the cyclical hormone stimulation that fuels the disease.
You are essentially starving the disease of its primary fuel source.
Exactly.
Okay, so we've talked about preventative measures and chronic pain, but I imagine there are also scenarios where surgeons don't have the luxury of time to plan this out over months, where it's a matter of life and death in the immediate moment.
Oh, absolutely. That brings us to malignant and emergency situations. Obviously, this includes aggressive treatments for already existing ovarian carcinoma.
Right.
But it also includes acute, terrifying emergencies like adnexal torsion.
Adnexal torsion, walk us through what a torsion is mechanically.
Okay, so the ovary is suspended in the pelvis by ligaments, which also house its blood vessels. In an adnexal torsion, the ovary physically twists on that supporting ligament. Think of twisting a garden hose.
Oh, yikes. Okay.
Yeah, it immediately cuts off its own arterial blood supply. Without rapid surgical intervention to untwist it, the tissue undergoes necrosis. It rapidly dies.
And if it dies?
If the tissue dies, or the damage is too catastrophic, the surgeon has no choice but to remove the ovary immediately to save the patient from severe infection and sepsis.
So a key takeaway here for everyone listening is that surgical menopause is emphatically not just early menopause.
No, not at all.
It's not a slightly sped up dimmer switch. It is an abrupt, medically induced halt to hormone production that leaves the body absolutely no time to slowly adapt. Which brings us to the immediate aftermath, the shock to the system.
Right, because the body's hormone factory is forcibly shut down rather than gradually decommissioned. The resulting physical fallout is not just early, it is uniquely severe and intense.
Yeah, I was reading through the symptom profiles in the British Menopause Society leaflets, and the phrase vasomotor symptoms comes up constantly.
Yeah.
Which is the clinical, highly sanitized way of saying your internal thermostat completely shatters.
That is a brilliant translation, actually. The hypothalamus in the brain acts as the body's internal thermostat, and it relies heavily on estrogen to function correctly.
Okay.
When you instantly remove all estrogen, the hypothalamus panics. It misreads the body's temperature, falsely believing it is dangerously overheating.
So it's a false alarm.
Exactly. And in response, it triggers massive vasodilation, widening the blood vessels to dump heat, and causes intense drenching sweats to cool down a fire that simply doesn't exist. We were talking about hot flushes and night sweats so severe that women have to change their bedding multiple times a night.
That sounds absolutely exhausting. I was also reading about the physical toll on the tissues themselves, and the genitourinary impacts sounded agonizing. We're talking about severe tissue degradation. Why does the sudden lack of estrogen cause the physical architecture there to just, well, break down?
Estrogen is the master architect for the tissues of the vulva, vagina, and lower urinary tract. It maintains tissue elasticity, ensures robust blood flow, and critically, it promotes the production of glycogen. Yeah, glycogen is the food source for the good bacteria, the lactobacilli that keep the vaginal microbiome acidic and protective.
Ah, okay. So without estrogen, you lose the glycogen, you starve the good bacteria, and the whole protective ecosystem collapses.
Exactly, the mechanism. The vaginal walls rapidly thin out, dry up, and become highly inflamed. This leads to profound vaginal dryness, highly painful intercourse, and because the microbiome is altered, a massive spike in recurrent, painful urinary tract infections.
That's just brutal. And we can't ignore the brain. The sources heavily document severe psychological shifts like overwhelming anxiety, depression, and deep brain fog. The brain is suddenly starved of the neurochemical messengers it relies on to regulate mood and cognition.
It's a huge adjustment.
But here's the thing. When we talk about menopause, the conversation is entirely monopolized by estrogen and progesterone. I want to ask about the other hormone, the one people universally associate with men.
What's fascinating here is the crucial, heavily underdiscussed role of testosterone in the female body. Society forgets that women naturally produce and require testosterone for optimal health.
Right. It's an essential part of the female chemical makeup. Where's the body manufacturing it?
Well, half of a woman's testosterone is produced in the adrenal glands, which sit on top of the kidneys.
Okay.
But the other 50% is produced directly by the ovaries. So the moment a surgeon removes both ovaries, they induce an instant, overnight, 50% drop in the body's circulating testosterone levels.
A 50% cliff overnight. That magnitude of loss has to have massive systemic consequences.
It fundamentally drains the battery. This dramatic, immediate loss of testosterone leads to a much more prominent loss of libido, a noticeable decrease in muscle strength, and a profound, bone-deep drain on overall energy levels compared to what is typically seen in natural menopause. Because in a natural gradual menopause, the postmenopausal ovary actually continues to produce small amounts of androgens, including testosterone, for years. But in surgical menopause, that biological safety net is just gone.
You know, pausing to think about all of this, I really want to linger on the heavy psychological burden for anyone listening to consider. The sheer human reality of it. The women undergoing this are often already navigating so much pre-existing trauma.
So much trauma.
They might be recovering from an intense, grueling cancer diagnosis, or they are carrying the deep existential genetic anxiety of a BRCA mutation. Or they have been suffering for a decade with the debilitating, life-pausing pain of severe endometriosis.
The clinical history leading up to the operating room is almost never easy. The surgery is usually the culmination of a very long, difficult medical journey.
Right. And then, on top of that underlying exhaustion, they go into an operating theater and wake up dealing with this massive, multi-front chemical shock. Their fertility is permanently, irreversibly gone. Their brain chemistry is completely altered. Their internal thermostat is broken, and their testosterone is slashed in half.
Yeah.
It is an overwhelming, staggering mountain to climb all at once.
Which is exactly why the medical management and intervention following the surgery is absolutely critical. And we are not just talking about treating uncomfortable hot flushes to make the patient more comfortable today. We're talking about playing the long game.
The long game.
Yes, the sudden lack of these hormones fundamentally alters a woman's long-term health trajectory and lifespan.
Because these hormones aren't just about reproduction or, avoiding night sweats. They are structural. They are highly protective.
Deeply protective. Women who undergo surgical menopause before the age of 45 face significantly, demonstrably increased risks for a whole host of severe degenerative conditions if those lost hormones are not synthetically replaced.
Like what?
Well, let's look at the cardiovascular system. Estrogen is incredibly protective for the heart. It helps keep blood vessels flexible and helps manage cholesterol levels.
Okay.
Without it, plaque builds up faster, leading to higher rates of cardiovascular disease and heart attacks at a much younger age.
I saw osteoporosis heavily featured in the sources as well. How does the lack of estrogen mechanically destroy the bones?
Think of estrogen as the body's master contractor on a construction site. In your bones, you constantly have a demolition crew called osteoclasts, breaking down old bone, and a building crew, osteoblasts, laying down new bone.
Okay, I'm following.
Estrogen regulates the demolition crew, keeping them in check. When estrogen vanishes overnight, the demolition crew goes into overdrive while the building crew takes a vacation.
Oh, that's not good.
No, the result is a rapid, dangerous thinning of bone density, leading to osteoporosis and severe fractures.
And the sources also point out severe neurological risks, right? Increased risks of cognitive impairment, early onset dementia, and even Parkinson's disease. The brain simply degrades faster without its protective chemical fuel.
The overarching data is stark. Studies show a clear increase in overall all-cause mortality in younger women who undergo this surgery and do not receive medical intervention. Their lifespan is statistically shortened.
Man. So what is the medical shield against all of this? How do we prevent this accelerated aging?
Hormone replacement therapy, commonly known as HRT. Clinical guidelines from all our sources strongly, unequivocally recommend that these women receive HRT immediately after surgery.
Immediately.
Yes, and crucially, they must continue it until at least the natural age of menopause, which again is around 51. The medical goal isn't enhancement, it's replacement. We are simply replacing what the ovaries would have naturally been producing during those vital protective years.
Okay, here's where it gets really interesting. I was reading through the specific prescribing guidelines for HRT, and, well, I have to play devil's advocate here based on the mechanics.
Okay, go for it.
Because my understanding of the standard medical rule was always this. If a woman has a hysterectomy, meaning her actual womb is completely removed along with her ovaries, doctors just prescribe her estrogen alone. I thought the only physiological reason you ever need to take progesterone is to protect the womb from cancer.
That is an incredibly sharp observation, and you are stating the gold standard clinical rule perfectly.
Right.
Generally speaking, if a woman has no womb, estrogen-only HRT is the absolute standard of care.
Right.
Conversely, if the wound is still physically intact, you absolutely must use combined HRT, which is estrogen paired with progestogen. If you give estrogen alone to a woman with a womb, it will cause the lining of the womb to thicken uncontrollably, which can eventually lead to endometrial cancer.
So the progestogen acts as a shield.
Exactly. The progestogen keeps that lining thin and safe.
Right. So if the womb is physically gone, removed during the surgery, why would a doctor ever prescribe combined HRT? Isn't giving progesterone to protect against endometrial tissue just, I don't know, fighting a ghost?
It sounds like fighting a ghost until we run into a very crucial clinical nuance. The endometriosis exception.
Ooh, let's explore that.
Let's look at a scenario where a woman had a hysterectomy and her ovaries removed specifically to treat severe, widespread endometriosis. In that highly specific scenario, clinical guidelines dictate that doctors still recommend continuous combined HRT, estrogen, and progestogen, even though she completely lacks a womb.
Wait, why? If the organ is gone, what is the progestogen physically protecting?
It is protecting the rest of the pelvic cavity from microscopic residual endometriosis. Remember, endometriosis is when tissue similar to the womb lining grows outside the womb.
Yeah.
Even with a spectacularly skilled surgeon scraping the pelvis clean, microscopic invisible deposits of that rogue tissue might remain on the bowel or the pelvic sidewalls after the hysterectomy. If you give that specific patient estrogen-only HRT, that estrogen acts like fertilizer, it can actually reactivate those microscopic residual deposits.
Wow, it wakes the disease back up.
Precisely. It can cause the excruciating pain to return, and much more worryingly, there is a small but documented theoretical risk that unopposed estrogen could stimulate those residual deposits to mutate and turn malignant over time.
Oh, that's terrifying.
So adding the progestogen keeps those rogue microscopic deposits permanently dormant. It is a fascinating, highly specific tailoring of care based entirely on the underlying reason for the surgery, rather than just the anatomy that is left over.
That makes incredible mechanical sense, but it really highlights just how meticulously individualized this medical treatment has to be. You can't just hand everyone the same blanket pill and send them home.
You really can't.
Speaking of which, the sources spend a lot of time delineating between the delivery methods for HRT. We're talking patches and gels versus oral pills. Is there actually a mechanical difference in how the body processes a patch versus a pill?
The difference is monumental, actually, and it entirely comes down to how the body metabolizes the hormones. Specifically, it relates to the risk of blood clots, or what we clinically call venous thromboembolism, or VTE.
Right, because whenever hormone therapies are discussed in the media, the risk of blood clots is always the giant warning label flashing on the screen.
And rightfully so. But the route of administration changes that risk profile entirely. When a woman swallows an oral estrogen tablet, it travels through the digestive system and goes straight to the liver to be processed. This is called first-pass metabolism.
First pass metabolism, okay.
Yeah. When the liver processes that sudden oral hit of estrogen, it goes into a slight overdrive and stimulates the production of extra clotting factors in the blood. This specific liver reaction is what slightly increases the patient's baseline risk of developing a dangerous blood clot.
But the patches, the gels, the transdermal methods, they physically bypass the liver.
That is the mechanical genius of it. Transdermal estrogen, meaning patches worn on the skin, or gels and sprays rubbed into the arms or thighs, absorbs directly through the skin into the bloodstream.
Oh, I see.
It entirely bypasses that first pass through the digestive system and the liver. Because the liver isn't forced to process it all at once, it doesn't puff out those extra clotting factors.
So the risk doesn't elevate.
Exactly. Transdermal estrogen does not increase the risk of VTE above the woman's normal, everyday baseline risk. Therefore, for women who have a BMI over 30, or who have a personal or family history of blood clots, or who suffer from certain types of migraines, transdermal estrogen is the strongly preferred, vastly safer clinical route.
If we connect this to the bigger picture, HRT in the context of surgical menopause isn't just a comfort measure. It's not just a lifestyle drug designed to stop the night sweats so you can get a decent night's sleep. Though, given the severity of the symptoms, getting a good night's sleep is obviously fundamentally important to surviving the day.
You are absolutely right to elevate its importance. It is fundamentally about replacing vital, structural chemical messengers that physically protect the heart, preserve the brain's architecture, and maintain the density of the bones.
Yeah.
It is about actively preserving a woman's long-term health trajectory and preventing terrible degenerative diseases that would otherwise take hold decades too early.
It is quite literally life-saving preventative maintenance.
It is the ultimate preventative maintenance, and it requires highly careful, ongoing dynamic management with a healthcare professional to get the delicate balance of dosages, the specific combinations of hormones, and the delivery methods exactly right for each individual woman's unique biology and surgical history.
So what does this all mean? Let's bring all these threads together. Surgical menopause is a jarring, violently abrupt medical event. It thrusts the human body into absolute hormone depletion overnight. It is the medical equivalent of literally pulling the plug on the ovaries' production of estrogen, progesterone, and a staggering half the body's entire testosterone supply.
And that sudden overnight drop causes not only severe, immediate physical and psychological symptoms, but it sets a dangerous stage for serious, life-shortening, long-term health risks if left completely unmanaged by the medical community.
But, and this is the most crucial, hopeful but of this entire deep dive, with the right targeted, scientifically backed hormone replacement therapy, tailored specifically to a woman's unique surgical history, her age, and her personal risk factors, those severe symptoms and looming long-term health risks can be highly successfully managed.
They really can.
Whether that's utilizing transdermal patches to cleverly bypass the liver and protect against blood clots, or maintaining progesterone for an endometriosis patient to fight off microscopic ghosts in a missing room, modern medicine has the sophisticated tools to turn the lights back on in the house.
It absolutely does. It requires dedicated patient advocacy, widespread education, and crucially, access to specialist care. But the profound protective benefits of proper, tailored HRT for these women are undeniable and heavily documented.
And to you, listening right now, whether you are facing the daunting prospect of this surgery yourself, whether you know a dear friend, a partner, or a family member who is currently navigating this intense transition, or whether you are simply fascinated by the incredibly complex mechanics of the human body, understanding these hidden chemical realities empowers you.
It really does.
It pulls the curtain back. It empowers you to ask better, sharper questions in the doctor's office, to seek out dedicated specialists when things don't feel right, and to fiercely advocate for better, more comprehensive healthcare.
Knowledge is the absolute best, most reliable tool we have for navigating these incredibly complex, often intimidating medical landscapes.
I want to leave you with a final, slightly different thought to mull over as we wrap up. Throughout this entire deep dive, we focused incredibly heavily on the physical removal of the ovaries, the very physical, visceral symptoms like drenching hot flushes, and the physical, structural protections against heart disease and bone density loss. But think about the brain for a second.
The deeply profound neurological impact of pulling that plug.
Right.
Given the severe neurological shifts caused by the sudden overnight absence of these vital chemical messengers, especially that dramatic cliff edge 50% drop in testosterone that governs energy and drive, how might the broader medical community better prepare women psychologically for a brain that suddenly has to figure out how to operate on a completely different chemical fuel? This raises such an important, often neglected question in standard care. We spend weeks meticulously prepping the physical body for the trauma of surgery, but are we dedicating anywhere near enough time to prepping the mind for an entirely new, deeply altered chemical reality?
It's something we all need to think about because
Right.
absolutely nobody should be dropped onto the freezing ice of the Arctic Circle without being given the chance, the resources, and the guidance to at least pack a warm winter coat. Thanks for joining us on this deep dive.